internal pouch. And sometimes people have not had surgery yet for colitis and polyposis, and they don't want to have a J-pouch operation. They feel, I've operated on some firemen, for example, active duty, they're on the top of the ladder fighting a fire, and they've got a J-pouch. And they know they are only going to be able to wait 45 minutes, an hour, maybe a little bit longer once they get the urge, and after that they're going to keep fighting the fire and may soil themselves. With a continent ileostomy, until you put your catheter in, nothing will come out. Well, you can wait many hours, the pouch will not burst inside, it won't rupture or perforate. Obviously, the longer you wait, the fuller your system gets, the more bloating you may feel, cramping, and if you wait all day, you may get nauseated and even start vomiting, because basically you've got a functional blockage. Waste and gas are not coming out till you catheterize. But at least if you're in the middle of fighting a fire, you don't have to worry about it. And you just do your job, and then so that's what we mean by patient preference or lifestyle. And the reason that's an issue because the most common operation for people who haven't had surgery yet for colitis or polyposis is the J-pouch. And the reason for that is you get to go to the bathroom the normal way. You don't need a tube, you don't need an appliance, you don't need any equipment, you need a bathroom and toilet paper.
May I ask a question?
Sure.
If you go from the J-pouch to an internal reservoir, can you still use the valve that you use to make the...
That's a very good question. 50% of the time when we operate on people where the J-pouch hasn't worked out for them, we can use that pouch and add on sections of intestine for the new stoma and the valve. 50% of the time we can't use the pouch. We have to remove it and make a new pouch from the remaining intestine. So that depends on the reason for the J-pouch failing, whether the pouch itself is healthy and it's the connection that's the issue, which is mainly the case. And the technical factors as we mobilize the pouch if it's not damaged during that process of freeing it from down where the rectum is. So the Coke pouch, which you see on the far left, has kind of a triangulated suture line. It's a folded pouch, and this spot can be a fistula. A fistula is an abnormal connection from the intestine to the outside, usually to the skin. And if this were to break down over months or years, even a little pinhole, bacteria would seep out, it would track out through an incision or next to the stoma. You get an abscess, it drains, and then you see waste or gas coming out, and you know it's coming from your intestine. That's a fistula. The other thing you see here is Marlex collar. This is the valve, and I'll show this in a little more detail later, but the problem with the Coke pouch has been the valve slips. If the valve slips out of position, the patient now has waste coming out of their stoma, they're incontinent, and they have trouble getting their tube in. So one way surgeons worked around that was to put Marlex mesh. Marlex mesh is a polypropylene material we use for sutures in many surgeries. It's great for hernia repairs because you get a lot of good scar tissue, so the hernia won't recur. But if you put Marlex around the intestine, over years, it tends to tighten slowly until it pinches that passageway where the tube has to go through and causes problems. So the Marlex mesh was very effective in preventing slip valves, but it was also very effective in creating fistulas. So we abandoned that. Most surgeons will not use a Marlex collar for a pouch. Then Dr. Barnett, who learned Dr. Koch's operation, met with Dr. Koch in the 70s and 80s, decided he would make some modifications in the pouch. And he made some of the most significant transformation of the Coke pouch of any surgeons doing continent diversion surgery. And one thing he did was he decided to replace the Marlex collar with a loop of intestine that wraps around the outside of the pouch. And then he changed the configuration of the pouch to make one long suture line instead of that triangulated one, which has a potential weak spot. So that became the Barnett continental intestinal reservoir. And we'll see some more pictures of all of these in a minute. Why do people want to have another operation? No one wants to have more than one operation. So let's say you had your colon and rectum and anal canal removed. You weren't a candidate for a J-pouch, or it wasn't available to you in those years. And now the question is, why undergo more surgery? And this is a partial list of all the reasons. And we talked a little bit about what it means to have a malfunctioning ileostomy. You know, most people, we're all very resilient, but outcomes are unpredictable. And it's as we all know, in this group, it's an emotional and psychological challenge sometimes, initially living with a conventional ileostomy, wearing an appliance. But there are also many physical issues that some people have that leads them to decide to have another operation and a different type of stoma. Advantages of any continent ileostomy stoma is that, as you saw in the pictures, it doesn't have a spout, it's flat to the skin. It's not designed to put an appliance over it, and it can be much lower down. And the typical ileostomy has to be somewhere up near your navel, near the waistline, so there's a big flat area for the appliance to adhere to. But here we can put it, we usually put it just above the pubic hairline, and that's more convenient for catheterizing. Here's how we make a Barnett pouch. This is where the end of the intestine was. Whether it used to be an ileostomy that malfunctioned, or the patient had their whole colon removed and now the end of the small intestine. So we put two loops of intestine next to each other, and that's when we're going to create a pouch. Nowadays we usually use surgical stapling devices. This shows a hand suturing method. Both work well. The stapling method creates a somewhat bigger pouch initially. Now, this part of the valve is going to become the valve, and this is going to be the collar. So just a few more pictures. You see the measurements that we take when we do that, and basically we grasp this segment, this 12 centimeter, 6-inch or so segment, pick it up in the middle, and we're going to telescope it into itself to make a double layer, and that's creating the valve. Now here we do several steps to make the valve stick in place. We strip off the lining that covers the blood vessels. This we call the mesentery, that carries the blood supply back and forth. We burn the surface of the intestine a little bit, very gingerly, very delicately, to create a situation where those two layers, when we double it into itself, will stick together and not unravel. So now you can see a bit of the valve. Here's the valve up here, and here's the instrument that's used to create it, to kind of push it into itself. And then we use stapling devices to fix it in place. And then you see we still have the pouches open. Now, here's a little opening here, and here's an end of the collar. This is going to go through here and wrap around to create the Barnett intestinal collar, which is different than the Koch pouch. This shows the intestine now being reattached to the pouch. We've kind of turned the pouch upside down, or right side up, I should say. And here's a completed pouch. So the intestine is reattached. This is the valve sticking in here, and the top will be the stoma. And here it's all finished. And you can see, kind of as a cutaway, here's the tip of the catheter. So after surgery, we leave a catheter in place, we suture it in place, connect it to a drainage bag or suction system, and allow things to heal without any pressure building up in them. So when we do a continent intestinal reservoir, you don't need to have a temporary loop ileostomy, which is usually done with a J-pouch operation. When we do J-pouches, we also want to allow the pouch to heal without any pressure building up, but the only way to manage it there is to do an ileostomy further upstream, so to speak, and let things heal for a couple months, and then another operation to close that temporary ileostomy. Here, we can rely on the catheter to allow the pouch to stay empty while it's healing, so pressure doesn't build up. And once it's healed satisfactorily, we take it out and teach the patient how to do their catheterizing, intubation, and go on for the rest of their life. So here's another schematic of the conventional Brook ileostomy, where the appliance would go over the external pouch, and the type of stoma for a continent ileostomy. And I mentioned T-pouch. Surgeons keep trying to modify the original Koch pouch because the original Koch pouch had a very high failure rate. It was 50-50 whether it was going to work or not. And surgeons will not do an operation with those odds. And many patients might say, I'm having so much trouble, it's worth any odds for me. But surgeons won't be enthusiastic about it. So many gastroenterologists, many surgeons in our country, based on the early experience, decided to advise against having a Koch pouch or a BCIR or any type of continent diversion. And even today, unfortunately, surgeons who you'd think would know better, and gastroenterologists who might know better, will tell patients, oh, you're thinking of a continent diversion, don't do it, it's nothing but trouble. And that is based on the very earliest experience with the Coke pouch. No reputable surgeon would do pouches with a very high failure rate. It would just be an operation